A little bit about Dr. Hatcher. She's a native Kansan, attended the first 2 years of medical school at the University of Kansas in Kansas City. She graduated from the OHSU Family Medicine Residency in 2012 and continues in the department as preventive medicine resident. She's also finishing a master's in public health at Portland State. She sees Clackamas County women's health patients at Richmond Clinic and works there on an urgent basis as well. She's the Health Policy Fellow at the Oregon Health Authority in the Department of Oregon Health Policy and Research. She's staff for the Patient-Centered Primary Care Home Program and also leads an evaluation project. She teaches in the department about continuous quality improvement. In addition, she is an active gardener. She loves to eat and cook and enjoys her children who are Hercules, the three-legged Great Dane, Kato, a long-haired ragdoll cat, and a recently adopted tortoiseshell kitten. I will say here that the talk is on panel management, applying population health and best evidence, and Dr. Hatcher has indicated that she has no relationships to disclose relating to the subject matter of this presentation. Enjoy. Thank you, Dr. Hatcher.
Well said. Just like an awkward.
Hi, so our room is a little bit awkward, so I'll step out here because I'm gonna advance my slides, and so I'll be in and out of the mic. So if you can't hear me, I know that that sometimes the what's it called?
Acoustics.
Like, yeah, well, just the pitch of my voice is kind of high, and so sometimes I know it's hard to hear. So let me know if you can't hear me. Oh, that's okay. Yeah, it was funny. He was talking about my children. One of my professors, actually, I'm traveling right now, but for about 10 days I'm going to be away. And he said, it's going to be really hard. This is the first time that you've been away from your kids this long. And I sort of laughed and I was like, I don't have kids. And he says, we talk about them all the time. And I was like, those are my dogs. So it really is, that's sort of how it is in my house. We actually have one more that we just adopted, a new pup too. So we've got 4 right now, so quite the household. But first of all, so I was hoping, I would like to hear from you. This is supposed to be sort of a workshop sort of feel to this presentation. I know many of you are probably here because you have questions, you're looking at doing this in your own practice. And so I would like to know first what people want to cover. Did anyone come in with a burning question today? I did exactly the same thing. I think I just want to see you do it, so I can't be upset about that. What does panel management mean? Yeah, go for it.
So, the use of registries, because we're kind of debating in our organization whether what we've got is sufficient or whether we should get a registry.
Yeah, so she wants to talk about registries. We're going to talk about that later. Anybody else? Yeah?
I was sort of fuming when I first started on my way over here because I had just left the meeting with my colleagues, at which we'd gotten a list to look at about here's the Medicaid patients who are Medicaid has assigned to you, anyone who's obviously wrong. And then another presenter saying we're about chronic pain, here's the patient who got chronic pain. And a couple of the folks in the room basically said, don't make me look at lists, I'm not going to be a list pusher as a clinician. And I sort of thought, where's
Yeah, I think we need to talk a little bit about change management. I put that into this topic and my other one, but I can add it in a little bit here too. Because that's a personal interest of mine, because it can be pretty tricky. Anybody else? So can anyone describe to me what they think of when they think of panel management? What does that mean? Is it like what Dr. Dillon said, you get a list of patients and you're supposed to tell people what you do with them?
For me, it means having, as opposed to the old model, which is you make an appointment, you come see me, I pay attention to you. It means paying attention to people regardless of them making appointments because we know they're part of our practice universe. That's the biggest change for us.
So care outside of the office visit.
Paying attention to them.
Yeah.
There's
First back here. Yeah. The same thing.
I was just going to say, finding ways to intervene on patients' health outside of the visit, either by some preventive health goals, which you can pull a list or not, or a diagnosis code, or whatever grouping you decide to apply to that. I was just going to say that it's applying evidence-based standards to your population, in addition to what the other two said, and then also being able to manage all of your patients.
Manage all of them. When we're here.
have found that, looking at the whole and trying to decide how to manage parts of it. For me, for instance, hepatitis C patients and patients over 400 pounds become panels
Yeah.
instead of being individuals.
Yeah, so I think a lot of you hit on these points and are kind of thinking along the same lines. I pulled some, I've tried to pepper with references that I put in the slides or at the end, so if you have questions, you can actually read about some of these papers yourself. Kaiser Permanente system has done a lot of the research on panel management. They really, as a system, took it on pretty early, and so they've got some of the older references about this. And so this is the definition that they've created, is what it means. To me, it's really about, I think a lot of you guys picked up some of these keywords, applying evidence at the population level. I think we've moved, in family medicine, we've done a good job of thinking about the whole patient. We do that a lot. We think about the whole patient at once, and now they're really asking us to think about the whole population, both in our practice, outside of our practice walls. Our population might actually include the people that aren't coming in to see us, but the people in our community and sort of our catchment areas and that sort of thing. And so we're bringing in, it takes a very different set of skills. For me, finishing my master's in public health, I get specific training in that, and a lot of medical schools and CME and so forth are adding in those sorts of curricular activities around population health. But for a lot of people, they really feel like they were trained to take care of one patient and the patient in front of them, and so this is a particularly difficult challenge for a lot of people right now. So these are some of the best practices that I pulled out from that article about panel management. And one of the things that people find is really important is that there's dedicated time. I hear sort of people about that, right? Because the problem with that is with some reimbursement models, if dedicated time isn't paid for, and people say that they can't do that. But the evidence shows that in order to really look at population health and do it well, there has to be somebody with dedicated time, whether it's a physician or not. I think you guys have had other talks on team-based care, but it takes dedicated time to look at it. It's not an easy add-on, because it requiring that you look at things from the population level, it requires sort of stepping back from individual office visits and making a plan. I think I have some more information about time and numbers in this later on. Information technology, luckily there are some tools to help us address these gaps. I think registries are a very great low-tech way to start that doesn't require buying software or some programming specialist, but an Excel spreadsheet. We all know how to use Excel. And so I think that is a nice piece of sort of low-hanging fruit that we can all start with. And then structured work processes completed on a routine basis. What does that mean, right? So that's the piece that it's more than getting an email from somebody in your clinic or your administration telling you that you need to look at your patient's A1C numbers, right? It's an actual thinking about the workflow. How do I do that? Where does it fit? How much time do I need? Who should be doing it? What are we going to do? And so forth. So this is a real broad overview. I'm going to get into the specifics as well. So in this, again, from the same article, the experience is that patients mostly like it, which is good. It's mostly implemented at Kaiser anyway without new funding. That doesn't mean that, so what they did is they took funding from some places and moved it towards other places. So it doesn't mean that they didn't change their funding. It means they didn't add overall funding at the bottom line in this particular study. And I think there were like 7 or 8 practices across the Kaiser region that they looked at different structures and different models. What's really important, but what happened is that when people were successful and they liked it, things quickly went full scale through the clinic. Things that work, things that people like, things that are easy to do, are easy to disseminate. And so that part was easier than starting it. Most people focus on a particular high-risk group when they start. And I'm going to talk a little bit more about some ideas that I have about which are some good starting places. And this is the time part that I talked about. So this was on average, this was the amount of per PCP time that was reserved per provider per month. So it's a lot of time, potentially. I mean, sometimes you can look at that and say, okay, that's 15 minutes a week on the low end per doc. Maybe that's reasonable. But other ones did a lot more than that. And if you think about every provider, that's potentially a lot of time. And a lot of uncompensated time, potentially, depending on what your model looks like. All right, so this is the change management part that I promised. These are some of the quotes. It doesn't make my day easier, but it makes it better. I like that one. Some doctors felt that it was giving them hope that some of their patients, the most difficult patients, they started to see changes for the first time after sort of years and years of banging their head against the wall. Some people find that less time outside of the office visit means less face-to-face time with patients. All sorts of staff have talked about this, physicians, nurses, medical assistants, people that spend more time on the phone, more time in front of the computer, less time in front of patients, sometimes find that their job is not as satisfying. And that's sort of a personal thing that I don't think we know that's going to happen until it happens. Like I said, I moonlight at Richmond Clinic in Southeast Portland, and my RNs spend their almost entire day on the phone, almost their entire day. And for some of them that works really well for them and they like it and they like the way that their job works. And some of them say, that's not why I went to nursing school. And so that's something to consider when you're going through this process. Patients also, when they don't like it, it's because patients worry that decisions aren't being made by their doctor. So even if that's not the case, even if the protocol was decided by the doctor, a lot of these models require shifting of communication from patient to provider time to patient to other staff time, whether that's clinical or otherwise. And the patients worry that they're being told to do things, and they just worry. They worry about the loss of control and the loss of, maybe that's not really what my doctor wanted me to do. Are you sure that that's what my doctor said? Are you sure this makes sense? There's still some issues around trust and patients not totally being invested or comfortable with the team care concept. They've been treated by their individual doctor in some cases for many, many, many years, and this is new for them too. And so when patients don't like it, that's what they're most often concerned about. So some of this managing change. Sorry, my slides are like super gorgeous. PowerPoint isn't really my thing. But physicians feel like they're losing control. So the other flip side of that is, so the patients don't necessarily feel like all of the information is coming from their doctors. The other side is that doctors have to give up some of this too. There's times when they have to make a decision and would leave the finer details to other people so that you can deal with this time issue and this uncompensated care issue. And some physicians they don't do that. The reason they went to medical school is because they're good at being in charge and good at leading the team, and that's a personality thing. It has to do with why a lot of people go to medical school, because they're so sort of driven and focused, and then to step back and let other people take over, it can be really, really challenging for a lot of doctors. And so when you're thinking about implementing something new, it's something to keep in mind, to think about your providers at your clinic. All of the pilot projects pretty much have been more successful when there's specific people in your clinic championing the project. Whether that's usually there's like a physician champion or a provider champion, nursing and staff. Because this doesn't work when the administration walks in and says this is what we're going to do. It does not work. Because of the change management problem. And so it's important to either find a provider or find someone in your practice that already is doing things that looks like this, already wants to do this, is interesting, already have skills, engage them early on and say, hey, do you want to lead this project? Or at least get them in on all the meetings in the very beginning on the front. It's really important to establish those champions. Some people actually name them officially. We have, patient centered renewal champions or something like that. I think what they were called at Richmond several years ago when we started our transformation. It's really important to measure the change that you're making and give that data back. So I'm a huge improvement sort of nerd. I mean, that's my bias. I like to measure things. I like to report them. That data is meaningful to me, but I think that's also because that's how we're trained from the very beginning. And so a lot of people like to see the data when it's uncomfortable and when it's hard, but then you can feed back to them data really quickly within the first 30 days of the project that you've already impacted X, Y, or Z outcome. really keeps people going and it keeps people motivating. Because there's both the managing change from starting and then there's managing stage change when you get to a maintenance perspective. And that keeping the data coming is really important for maintenance. And then the other thing is warm handoff. So when you're implementing a project like this, the warm handoffs are actually meant to be for the patients so that they understand, so that they get something more than a letter that says we're starting this new process. But for some people, it may actually take a conversation with their doctor at an appointment that says, so I'm going to start this new project about diabetes. You have diabetes. You're going to be hearing from my nurse now, potentially a lot more frequently than you've heard from me. And then you introduce your nurse, and your nurse comes in the room. That is a really time-intensive process at the beginning, but I found that it makes the patients much more invested in this process. I participated in a couple different particular disease-specific registry type projects around depression and diabetes, and the follow-up of the patients that are referred to these programs is much, much, much higher when they've actually met the nurse that I'm referring them to, than if I just tell them I'm going to enroll you to the person in this program and you're going to get a phone call. The patients do better if they can then see the face of the person that they're talking to on the phone. Topic selection. So where do we start? So I think this was the comment earlier before, is that it's kind of hard to imagine the whole world of population health, and you're supposed to now take on sort of all of this stuff. There's some data, it's in my other presentation, but there's some information about, with all the preventive care things that we're supposed to do and all the chronic care management that we're supposed to do, it adds hours and hours and hours to our day that it's literally not possible to take care of our patients right now in the model that we're doing. And so there's a lot of stuff we could start with, because there's a lot of stuff that I think we all think that maybe we're not doing. And so picking the topic is really important. And this especially for your first project, because if that first project fails, which is okay, it happens, but it's going to make it a lot harder to convince everyone to keep going if the first topic isn't the right topic. So oftentimes right now we're picking these topics because it's being incentivized by some sort of payment program. There's a dollar amount out there, we decide to shoot for it, and that's how we pick our topics. They should also be evidence-based, simple and clear. The easiest projects are going to be really straightforward, just easy for everyone to understand, easier to explain in the elevator speech, so I call it, so that everyone knows what you're doing. And I'm going to talk a little bit more about this evidence part in a minute. And the other thing is to think about, I really think the data needs to come within the first 30 days of the project. And so you have to aim for something where you can improve incrementally. If your goal is to get down A1Cs as your first project, which is fine, a lot of people are doing that, you're not going to see changes in your numbers for early as 3 months, maybe 6, 9 months, or a year. And so it's going to be really hard if that's your first project and you're not going to get data back in time to keep everybody motivated. Registry. This is one of my favorite things, so I'm glad somebody wanted to talk about this. Because at its basic, this is an Excel spreadsheet that's saved somewhere on the computer hard drive system at your work. It's got a listing of your patients in it, it's got the things you want to accomplish on one side, and you just go through and check off the boxes. The whole basis, the whole purpose of a registry is so everyone on the team understands what's going on right now. You can look at the registry, and anybody, if I go out of town and someone calls about this, they can look up and see this patient is due for this, and it's right there. You don't have to go through chart notes. I don't have to remember it. I don't have to tell someone else. Everyone puts in the same thing in the spreadsheet. Everyone knows what's going on.
But that's dependent upon data entry, correct?
Absolutely.
You can have errors, right? And so they have these commercially available products that are disease registries that can interface with your EHR and pull your data for you, right?
Totally.
Okay.
Yes. So there's two kinds of so it depends on what kind of project you're doing. I can give you some examples. So one of my favorite topics to take on first is prenatal care. Because for most, granted this has got to be, it depends on what your practice looks like, but for most family docs, you don't have that many patients up in the air at one time, and you were probably doing something like this in your head, and you had just never written it down before. And so you've really been doing this for some time, you just didn't know what you're doing, and so it's easy, I think, for people to understand this as a first project. And so the way, and because of the type of data, it tends to work better in a spreadsheet because it takes some programming manipulation in order to get the module to sort of spit out exactly what you want. Whereas some of this ends up being handed to her, just ends up being more reasonable and easier to do. And so a prenatal database is going to look like, it's going to have a listing of all your patients, their due dates, their entered to prenatal care. Your listing of what you've decided in your clinic are the must-have elements of their care. And then anybody can know if it's there or not. And it's really easy then to transition to not being me, the doctor, has to remember that so-and-so hasn't been screened for X yet. But I can very easily transition to that somebody else that could literally be, doesn't have to even be an RN at that point because it's pretty straightforward. To have call everyone and say, hey, I see you haven't had X screening and that sort of thing. So that's the most basic form of a registry, is literally a spreadsheet. You can get really complicated, and there are a lot of commercially available products, both standalone and integrated to your EMR, that pull the fields for you. They tell you, it will automatically update with the patient's most recent A1C and that sort of thing. And we're going to talk a little bit more about that process. But like I said, this is my favorite first project because I think we all have been doing this for some subset of our patients. For me, I just think of prenatal care because as a resident, I take care of like 6 patients at a time or something, and that's like a reason why I was essentially keeping this database in my head. And so it's easy for me to understand when it went on the paper, oh, this makes way more sense, it's way easier to keep track of. And so it's finding that topic for your providers that they've sort of been doing this anyway. And making it automated. I mean, that's the whole point, is we're trying to create a system that produces less errors. And most of the errors in medicine, most of the patient safety errors are created by forgetting. Everyone was well-intended. They just didn't remember what they set out to remember. And these sort of systems make those things automated and make it much harder to forget and build in that accountability. So to do it, this is the steps to create a registry. Is that the first thing you do is you identify the list, right? That's the list. We've all received that list in our email box. These are your patients with X. I got a chronic pain list. I get one of those every month, I think. And then the next thing you have to do, and so this is the step. This is going beyond the list in your email, and this is the most basic steps that it takes to create a registry. So the next step is that person's provider has to review the list for appropriateness. So chronic pain is a good example. The list for me is generated by a staff person, and they query the chart and they spit out a list of everyone that's had patients at month 1, month 2, and month 3. They've had 3 months in a row of pain medicine prescriptions or something like that. They set up their parameters. They spit out the list for me. And then I look at the list and say, so-and-so's on hospice, and they're within 2 weeks of life. I'm pulling them off the list because it's not appropriate. And so then you go through the list. So-and-so moved away, and I know that. They're off the list. And so the first step is just who are their provider, and it has to be the person that knows them, goes through the list to essentially clean your data to make it as simple as possible. The next thing that happens is the treatment decision, and this could be made in several different ways. Usually it's also the provider or a team of people or the clinic deciding this is our evidence-based treatment, this is what we want to do. And so it's going to be your threshold, so it's going to say that of whatever your first topic is going to be. It's the decision of these are the elements of prenatal care that we think everyone should have. That's the decision point. Okay, and it's whatever it is. This is the goal for hemoglobin A1C. This is the goal for blood pressure. This is this, and this is what we're going to do about it if our patient is different from that goal. Does that make sense? Okay, so that's the first step. And then the next is the follow-up communication protocol with the patient. And so this often ends up being a protocol because especially if you send it to somebody that doesn't have a lot of medical expertise, they're going to need to know. It's literally like a flow chart. We did one about one of my residents in the class that I teach decided that he, as a male provider, wants to get better, wants to make sure that his all of his pap smears are up to date. He felt sort of uncomfortable with the procedure. He wasn't getting a lot of them, and so he decided, because of those, that's why he picked this topic, that he was going to tackle pap smears in his resident practice. And so he wanted to craft a letter that went out to all of his patients, and he was really surprised at how quickly you can get yourself in a huge heap of trouble if you don't think through this follow-up communication part. Because what happens if the address comes back? How many times are they supposed to call? Who can leave messages? What does the message say? Like, this whole flow chart, really, to be efficient, think it out ahead of time, and it actually saves you a ton of time in the end. And obviously, that's not protocol. I can't make that protocol by myself. I need to make that protocol with the staff that's actually going to be carrying out, because they're going to tell me, hey, so it doesn't work for me to send letters, nobody is ever at the same address, I need to call everybody or whatever. And they're going to know the details of that about my patients when I don't know, because I'm not the one sending out the letters normally. Okay, so this was the part of the example that I was talking about. So, and I'm actually going to go through sort of another piece of this, which is the evidence part, because it's really important that when you make that decision, when you decide this is the threshold that I want for my patients, that you pick a threshold that is evidence-based, well accepted, and sort of time-proof in a way. Because if you pick something that's rapidly going to go up to date by the time you finish your project, if the goal has changed, you're just really going to be frustrated. So we're going to go through the evidence part in a bit too, but so this was the project that we did with one of the residents. So first thing we queried and made a list of all the women in his practice of a certain age, and it spit out all the names. Then we realized that we really want to make sure that all these women haven't had a hysterectomy, they still have a cervix, for example, that sort of thing, and so we cleaned the list of that. So we changed our results. So the list that we created were that women 21 to 29 with an intact cervix and no PAP result for the last 3 years. So that was one list. The other list was women 30 to 65 with an intact cervix and no HPV result for the last 5 years. And so this is how we decided to do it because of the practices of PAP and HPV testing in our practice. This would be really different if you've never done HPV testing, for example, because the guideline's going to be different. Or if you've only done, if you haven't done mandatory HPV testing on women over a certain age, then you're going to have to pick different numbers. And so this is going to look different. It's not always as simple as what does the evidence say and what should the guideline be, but you actually have to think it through in my practice. And I find it easier just to take some examples and say, okay, I'm a patient with this. Is the guideline going to apply to me? And try to just troubleshoot all of those one-offs to keep yourself out of trouble. So then you review the list for appropriateness of inclusion, outreach to schedule a patient, correcting the chart. So during the outreach process, your data gets a little bit better because your numbers automatically improve, because in contacting the patients you found out that 10% of them all had their PAPs last year at Planned Parenthood, and they send you the result, and now you don't have to count them in your numerator anymore, which is nice. And then once you've done it, you run the list again, compare your starting number of people that didn't have PAPs to your ending number of people with PAPs, and you have your first result, which you can feed back to everyone and say you have a whatever % improvement in the number of patients that are up to date on their PAPs. And so that's how the process feeds forward, because then everyone gets excited. My particular resident found this to be very useful and got to do a lot of public exams, which was part of the process as he wanted to improve his skills. But it also didn't take very long to get his patients up to date. So then you decide, do you want to run the cycle again? Do you want to make changes? Do you want to outreach to a different group? And so forth. So this is all a little bit abstract, but we're going to talk about some more specific examples too. Okay, so I was talking about the evidence part. So before we get here, if you were going to attack this particular problem, I want to bring all my patients up to date on their cervical cancer screening. Where would you go? How would you figure out how often you're supposed to test them? Like, where would you start? ASCCP?
USPSTF.
USPSTF? Okay, well, that one's on the word, that helps. No one's saying anything? No one's saying ACOG? Okay. So, So that's the first problem. Although all of those in this case happen to be right, depending on the time. Right, and that's because of what time of year it is. If you would have done this query, a year and a half, 2 years ago, then all of those sources would have had a different answer for you, which is potentially a major problem if you're about to embark on a huge improvement project. Like I said, you want it to be time-proof. You want to know that you picked the right guideline so that a year from now, you don't have to change your targets, especially if we're going after this for performance. Think about what's going to happen if you pick the wrong guideline, and then 6 months from now, the performance metric comes out, and it's not what and your guideline wasn't up to date, and then you're kind of in a big world of hurt because you aren't going to get paid for all the work that you did. So this is really critical. So what I've done is I've included a list of trusted sources, and these are the places that you should go to look. A lot of people, when I asked this question, I just surveyed my teammates and said, where would you go to find, and I'm sort of the pap smear queen, and so I will already beat it into their heads and they knew where they were supposed to go. But typically the answers are get things like, I would Google Scholar search pap smear, or I would go to UpToDate, and I'm like, okay. Or I would go to PubMed, which is also fine, we're gonna talk about PubMed in a minute. But for this level, for a quality improvement project that's clinic-wide, you want a guideline, because it's just going to cause problems otherwise. So National Guideline Clearinghouse, if you go, no, it's okay. So this is actually the pap smear one, and it lists out ACOG, ACSSP, and USPSTF, and then in the bottom it actually gives you this grid where it compares the guidelines and tells you if they agree or not. So this is great. And then so I just gave you that. I put this because you guys have the slides, and in case you need these links, I just put the rest of these in here so you can see the kind of things that they give you. So this is another one that can, if you're having trouble finding information, this was really good when a lot of hospitals were going through the elective induction of labor conversation of how many weeks they were going to say that you could electively induce women. NICE was one of the first people that had a really good guideline about that. And so I always include this on the list because they're great. Choosing wisely. Who knows about choosing wisely? Okay, so if you don't know what choosing wisely is, what they did is they asked the professional societies to each generate a list of the top most wasted procedures. Either for whatever reason they were harmful, they didn't work, they are too expensive, and so forth. This is now sort of like the bandwagon scenario, in that there are many, many professional societies, there are many, many examples and lists, and all of the stuff has been generated. But what's great about choosing wisely, in addition to just having really straightforward, easy to understand information, is they have patient information. And so when you're considering, because as we talked about earlier, sometimes it's the patients that don't like this transition. So this is a really good place to think about getting patient materials. It really explains, the one on EKGs is amazing. It literally says, like, if you get an EKG and you shouldn't have one, they're going to give you some invasive procedure on your heart that you don't need. It's really sort of scary. I mean, some of them are better worded. The colon cancer screening, it isn't as strong, but there's some good ones and bad ones. But if you look at these, there's some really good materials in here. Oh, this one's fun. The reason I brought it here, sorry, my slide answer, I keep changing my mind. I want to go on to the next slide. This one's great because how many of you had this conversation with a patient that is 18 and her mom and grandma send you in, yep, she sent you in and says, she's 18, she needs her pap smear today. And I'm like, no, really, I promise you she doesn't. And that is a really hard sell. And if I don't know the patient, I don't know the patient's mom, because if the 18-year-old is my patient, I've never met her mom doesn't know me at all and doesn't believe me, then I've got a backup source, which is really nice. So if you're going to go to PubMed, I recommend the PICO method. Is this familiar to people? Yeah, about half and half. Okay, so, and it's in general, I think it's a good idea when you're talking about your improvement to think about, how do I make that query? What do I ask the registry? What do I ask the medical record? How do I figure out which patients I need to include and get all the pieces so that your data is really clean? So, and so there's 4 categories you think about. The first being patient. So who is it? Is it children and adults? Is it pregnant women, people with specific problem, ages? And then you look at the intervention. Am I screening something? Am I treating something? Am I diagnosing something? When you're looking at comparison, this is usually for the treatment part. But in general, it is for, as we just talked about with colon cancer screening, there's comparators in colon cancer screening too. And then the outcome. It's really important to characterize your patients as acute or chronic for a lot of these problems. When you're talking your medical record, they want to know, is this a problem that happened once? Is it a problem that happened 10 times? And help you figure out what those fields should be. So, PubMed. So if you're going to go to PubMed, it's fine. That's what we did in medical school, and so many of us are trained to do that. But use your MESH database. I'm going to show you why. So the librarians were here earlier. One of my really good friends is a librarian, and so she likes to talk to me about this a lot, because I still like PubMed. I like to look at the primary literature. I like to know where this stuff came from. But it takes a little practice. So when you have to learn what the terms mean. It doesn't take that long for this search. It took me a couple minutes to generate. But what's funny is the words come up different than you think, and it has to do with how it picks. So I would look for pap smear, obviously, and in MESH this comes up vaginal smears. It's the only one it gives me, so it's not hard to figure that out. And it explains them, so you know, and it's off the bottom here, but it says Papicolo test right there. So you know that when I put in pap smear, if I was thinking about that, this is actually where I want to be. And I'll show you why you're going to do this. So when I put in MESH, when I do a MESH search and I'm in PubMed, do you see my results up there? 1 to 20 of 345? That's what MESH does for you. So if you're going to go to PubMed, it's fine, but don't go there unless you're going to use MESH, because it's just painful. Do you know how many search results? I don't know if I left it in here. Let's see if it's in my next slide.
It was a couple before.
It was
It said
before that.
15,000.
15,000 when I just looked for pap smear, and
This one?
I think it's one more back. Yeah, when I looked for pap smear and screening in PubMed, 15,000 results. You're just, I mean, that's a needle in a haystack. There's no way, there's just no way. And so this is much better, much more manageable. So this is my little plug for quality improvement for other reasons besides performance-based payment, is that when you recertify with your, you have to do these AB, FM, MCFP Part 4 modules, and there's a list that they give you of modules. It's possible to get those ahead of time. And if you do this sort of process, you will be able to meet the requirements for this module. This is all it is. This is all they're asking you to do, is pick patients, make an improvement, record your success. And so doing this, just make sure that when you're going to go through your improvement process, if you pick one on the list, it's really nice because if you know you're going to take the test soon. But also just know that if you look at the module ahead of time, it's really helpful, because you don't want to go through your whole process and collect things and then not have that be exactly what they wanted. And so if you know that's coming up for you in the future, just make sure that you've gone to their website and figured that out first. So this is the rest of the references. This is where I got the pap smear screening, most up-to-date pap smear screening. And we still have about 10 minutes or less if you guys are going to fire away with questions. Nobody likes QI as much as I do, it's okay.
We found that that with the EHR system that we have, it's really hard to run reports unless you're a report writer. And the people that write the reports for us have defined things in certain ways. And I would just suggest that you know how they define their reports. Because we, for instance, have a grant to improve cervical cancer screening rates. And it's not going up, and we've got all of our health department pap smears in and our outside gynecology pap smears in, and the rate's still not going up. And it turns out that the way that they define it on the report, you have to have put a certain couple codes in the past surgical history field rather than editing some other field, which is how we were doing it.
Right.
And so all of those women who had hysterectomies are still included in the denominator, so it kind of didn't matter because there were a lot of people with hysterectomy. So what that you added 100 pap smears? It didn't really change much from 53% to 54%. You know what I mean? So don't do a bunch of work until you know how you've defined the report that you're using.
Yeah, so before you go, so I gave an example of what this one person and I did about their one panel, and I think then, you know, it gives you an opportunity to pilot that. You should always pilot with one provider first. You should always pilot with a meaningful, a reasonable amount of patients first to find those problems. And that's why I find the PICO question really helpful, because if you have a well-defined PICO question and you have all of those things written down, it's easier for me to communicate with someone to generate a report and to remember which fields, because I frequently will generate a report and then I'll remember, oh yeah, I should have asked about this, or I should have remembered about this. And if I do the PICO first, then it helps me sort of narrow down that population, and it's also a easy to understand and communicate format. So when you're talking to someone that's building reports, it may help them as well, figure out what you need, because we all remember about hysterectomies, but obviously somebody that is sitting in a computer and doesn't see patients isn't going to understand all of that. And so piloting it, I didn't include that in the steps because I just did one project. So that you do the one cycle, and then you refine before you spread it out to everyone else. It's a very good point.
So our finding is that we're not so much being paid for performance, we're being not penalized for performance. Yeah, and you know, we're not in an integrated system. None of our EHRs talk to each other. There are lots of women in our practice who have their mammals and paths with the gynecologist outside of our EHR. They're not integrated. They might be a Planned Parenthood, they might be at the health department, they might be in other private practice worlds, and just the manual effort and staffing around collecting all of that and somehow putting it in a data form that's retrievable into our EHR is just a little overwhelming. You know,
I agree with you.
that's like step one, is collect all the data appropriately, and it's everywhere.
And that's
It's
why I
all over the
encourage
place.
people to start small and to start with the one diagnosis. I like diagnoses that are, so there's a lot of different ways to do it. The people pick diabetes because it's frequently something that, you know, people are getting paid for. It's easy to understand. It's, you know, there's a module about it, but it you have to start somewhere. And so I mean, even the big clinics, you know, that do a lot of it, they may only be doing care management per se for a couple diagnosis codes, and that's what they can do with the resources they have. But it spreads. That's the thing, is like, even though you're doing care management for this diagnosis code, that training and that team cooperation and the sort of the thinking mode gets spread throughout the whole practice pretty quickly, because it's really easy to see your patients just do so much better. And then you start thinking, okay, so who else am I going to do this for? And those principles start applying across the board. So I hear you. I know it's overwhelming. I'm terrible with computers. You can tell because my PowerPoint slides are so horrible. And so I really need a lot of help when it comes to this stuff. And so it's really just about biting off small parts at a time. Dr. Saltz.
So it's also possible, and I think if you're really creative, it's possible to find other data sources that could work for you. So if you happen to be in a community where a lot of the patients are in a particular CCO, then maybe claims data are going to work better for you, because the claims data will pay for pap smears. Or maybe you have a lab, and no matter where the people get the pap smears, they all seem to go to the same lab. Whether
Exactly
it's
right. So I'm specifically, so I started with this thinking of claims data. Because
Yes.
in fact, we're being penalized on the basis of claims data
Right.
mostly because payers are using only claims data.
Right.
And we're trying to then go, and that's 9 months old because
Right.
of all claims
Right.
data. And so then we're going to our EHR and saying, well, how can we prove that this has been done within the last 9 months and we're up to date and correct their data? And then you're going on the Providence website to correct them because their claims data is old
Right.
and incorrect. I mean, it just goes around and around, but the
It
data
does.
is so cumbersome, so.
So we've been doing some work down at Ocean, and the discrepancy between EHR data and claims data is substantial.
Absolutely.
And there's some things that the claims data measure better, like whether a prescription was filled.
And tax
We can measure whether the prescription was written, but we can't measure whether it was filled. And of course, very few practices have the resources to really know how to drill into that data or use it, and that's where I think partnering up with others in your IPA or others in your CCO group, because it is a really close to impossible task depending on how you're organized and what your information sources are. So you kind of have to start with what you can get. Some of this is like, where do you hunt the guy that hunts for his keys under the light, right? You gotta, I'm gonna work on the things I can actually work on. And then you start getting better at the process. And then you find out what the holes are in the system. Because I'm very fearful that a lot of family doctors are gonna discover that the EHR they thought was the best choice ends up not being the best choice at all 5 years hence, and then you have a different set of problems.
I think it's important that, the EHR looks for data in a defined box. And I think there's a couple ways to go about it. One is either that you can modify your search to look for a different box, or you can modify your practice to put the right data in the right box, or the right data in a different box. That has to match. So sometimes, like our EHR, I can't get the data out because it's looking for a different box, or the data comes in a different box, or the data doesn't come in at all. So sometimes our office staff has to modify our practice to get the data in that box. And then once you start doing that, whether it's pap smear, colorectal cancer, now you've put all this data in, and now it's actually accurate because you've called patients and you've done pretty much a manual chart audit for the missing data. Now that it's good, but now it's important to keep that ball rolling and keep it good. So, something like colorectal cancer or pap smear, you're looking 3 to 5 out. That means annually during Cervical Cancer Awareness Month, we do it again every year, and we send out the CDC glossy to those people who in that year now have fallen out because of whether they just turned 21 or now they've no longer than 3 or 5 years. And if you don't keep it going, then your data will decline, either that you're not doing it or your data is not getting the right box.
And that's why I really like to start with the ones that are like Q whatever year screening, because it is a concrete number of people that are manageable, and once they're done until the next year, as opposed to something with diabetes that's like rolling and forever, and it can be a little bit more overwhelming. So your first product, I really like cervical cancer screening or colon cancer screening or something else like that.
I have a question for the group, just curious. How many people here think that reporting data improves care?
Reporting data?
I think seeing it myself has improved care.
Well,
But I don't necessarily know that reporting it to someone else has improved our care. I
Well,
think-
just let me let's talk about it just for a second, because if you look at the experience with hospitals with critical measurements around cardiac care and stuff, it was very clear after the Medicare did this for 5 to 10 years that the top quartile performers had significantly lower death rates and lower costs than the bottom quartile performers. And that when they started, the hospitals all complained that they couldn't get the data and that the data wasn't accurate. Well, they pretty quickly got accurate data, and then it pretty quickly became clear that reporting the data moved the dots and that care improved. So Medicare is, at least based on the hospital experience, believes very strongly that reporting data is going to improve care, and that just the process is going to force us to improve the data collection.
I'm stealing this from someone else that I heard it from on a site visit this year, but they talked about the grief reaction when a provider sees their own data for the first time. Yeah, and so at first you're like, this can't be right, it's not my data, it can't be right, and then you start bargaining, and you're like, well, maybe if I took out these patients, then it would look better, and so forth. But the bottom line is that when you see your own data, people are competitive, they don't want to see we have a green dot, red dot visual measure system, and I was really bad about printing AVSs after visit summaries, and I was always like the only red dot up there, the bad kid, and I hated it every week, and now I consistently print 50% every time, every week, no exceptions, because I'm competitive by nature, and I couldn't deal with being the only one that had it figured out.
I think that these reports based on good data can be very useful to promote providers into better care. I think we all need to take independent responsibility to make sure the data is accurate.
There you go.
In our community, you've probably all received similar reports that tell you how crappy you are from certain insurers. I drilled down on the data looking at these reports from 2 independent insurance companies in the state, as well as one of the data aggregators that gives you reports. I'm not going to name any names. And the error rates, when I looked at specific patients, I obtained my patient list and went back and did a chart review on hundreds of patients. The error rate was between 90 and 100% on my reports. There wasn't one aggregator, that wasn't one insurance company, that was on 3 separate reports. So I would caution everybody, before you take these reports to heart, you spend a day on them going back and looking through your specific data, drilling down. And then hold these companies accountable for the public reports they're putting on the websites and their patient information about your quality of care is based on erroneous data. Because this is actually pretty serious.
I think what somebody said about learning to put, you have to retrain your whole practice to then enter in a different box. And it's really the data that comes out is a direct reflection of the data that goes in. I mean, before we started doing cervical cancer screening, I wasn't that great at making sure that, you know, that hysterectomy field looked the same way every time. And so that means whoever's running the report has to look for 5 or 6 different codes. And so there is the process of training. I mean, in addition to what you're saying, I mean, what I was talking about today, there's the whole big field of data and aggregate data and claims data. I was talking about provider-specific sort of data as a way to drive your practice, but it still applies there. That if you've got a provider that isn't filling out the boxes right, it's going to really cause lots of problems. And like somebody else said, if your data comes back and it doesn't include really critical pieces of information, you have to go back and figure out why.
So we did the diabetes, ABFM, PPM project. We straddled it over 2 years, so we actually got Medicare payments for both years. If anyone has more than about 20% Medicare in their payer mix, I think it is one of the several good ways to start.
Yep.
One of our subsequent projects, actually, we had put a thing into place where all our MAs were trained to do vaccines, to use the alert system. You look up every child at every visit, and we went from 54 to 64% in a year. Kids who are fully immunized at 2. So, you know, we're all the kids who got A, 64% isn't really what you want to get. What would it take to move it up? And the kids who were still unvaccinated, who had parents who agreed, were the kids who weren't coming in. So we basically have, I now think about it, I guess, in your framing, a panel, which is all the kids who were born in a given month who are under 2. And our lead medical assistant tracks them through time and just does well care recalls. So that's the one system that's running that doesn't take hardly any provider involvement, because there's not like inclusion and exclusion, and except for the occasional child who maybe gets their well care elsewhere. So that would be another interesting starter project, because it's also pretty straightforward.
And I gave this talk, so I went into this talk not knowing who was going to show up. And so if I hit the wrong level, because some of you guys actually sound like you've been doing this for a while and are a little bit more advanced than what I presented today. So if I'm happy to do one-on-ones, that's the sort of 2.0 or 3.0 of some of these questions if you guys want to contact me afterwards, because when it comes to figuring out these metrics, like I said, for some weird reason, nobody likes this stuff as much as I do. So so if this talk was at the wrong level and you're already doing it, just let me know and I'm happy to follow up with you afterwards.
So when you get ready to have the next session, you know, when you move to the next level with this, the one thing I'd add that I think is important and that doesn't get talked about at IHI enough is, as you do these projects, take great care to actually write down in a log each decision you make. So you just described the process. Now the question is, if you wrote that down and I took that to our Gabriel Park Clinic and we did it, would it work? That's how quality improvement becomes research. And if we find out that your process works better in other practices, better than his process does, we need a paper about that so people stop using the one that doesn't work right away. Because what you're describing has a lot of trial and error to it. And trial and error is where you find out things that work, but it doesn't address the generalizability question. Could that work in every practice in the room? Well, the only way to do it is to try it. And the only way to try it is to record each step so that you chose these definitions of people's pap smears. Or I showed you this morning, we picked 30 months as our mammogram cutoff. That may seem artificially long to you, Maybe we should have picked 24 months or 18 months. It's a 2-year recommendation. Now, if we picked a different number, then our outcomes would look different. And does it matter from one practice to the next, what outcome you pick? So this process is at the front line level. When you move back one step, we've got to have a science about how to standardize this so that we don't have to invent every single wheel over and over again.
Yeah, I totally agree with you. I haven't been to a practice so far that didn't have something that they could write up that they haven't. I swear to you, everywhere I have been, I was like, please write this up.
Record the method in a log, so if somebody else followed your directions, they could do exactly the same thing to see if it worked someplace else.
I mean, can you really write it up though and publish it if you didn't really design it, but you were just kind of making it up as you go along? I mean, that's what we tend to do in our practices. We say, well, it's kind of, let me try this.
Right, so I would say that you may or may not be able to write up a project you did in your practice. If you did a systematic project in your practice and you wrote up the standard and then you had 5 other practices start it, that you can write up. Everybody wants those papers because it isn't an N of 1 story. It's an N of 1 story that worked 4 or 5 other places, and we all need to read that paper, okay? So it's the next step after that. It's how you work with each other that creates the papers.
That's usually how things start with case reports, single case reports, and then they try to see if they can find a way to generalize what happened, and then you just.
So your paper about
moves
what
up
you
in
did in your
power.
practice would be a little brief report. We did this and we think it worked. But then you find other places to replicate it, and you get that IRB approved, and you get somebody like Orprin to help sponsor it. And eventually that's the science I was talking about this morning. So the key thing is to record your steps so that it could be reproduced by somebody who read your steps, okay?
Well, and actually, as I think about it, Family Practice Management did
Yes.
they published 2 papers for me that were exactly solving real-world problems in our practice in an iterative, improvisational sort of a way, and having some just very vague data. But that, because of the context of that journal, they actually are really willing to publish
Yeah, and
one
that
practice,
also-
one project.
Yeah, that journal is a gold mine for how to do these sort of projects. It's by far, I mean, I didn't talk about sort of improvement science references, but I'm an IHI groupie, obviously. So the IHI website has some really great open source information, but the other half of my references that I usually use are from Family Practice Management. It's a really great source.
The comment I'd make to Paul's comment is, I found the same problem. When we got reports from Pap smears from some of the insurance companies that wasn't doing Pap smears. So we looked at it, and what I found out is because we're a method 2 billing, our billing was being put in on a different bill instead of a UB92 or a HICMA 1500. Instead of a HICMA 1500, it was going on a UB92, and it wasn't being registered to me at all.
Right.
And so we were doing them, but they weren't coming through on billing data. And the reason I bring that up is I think as organizations and the academy, and as a group, we shouldn't be just sitting and all digging into 100 cases to see what they did wrong. We should be trying to figure out how to get them do it right going forward so that the data is helpful. And having spent a lot of time on Q Corp and looking at trying to get information, the largest insurer in Oregon can't give you good data.
Right. Exactly.
Because they have nothing but claims data. And it's just not reliable because people don't code well. So, I mean, we've got a real problem, and that is getting to the point that we actually have information that we can use.
When they post that data to the website, indicate whether you're a good doctor or a bad doctor, like.
Well, and there's the good doctor, bad doctor, and then there's we're withholding your payments.
And that's why the Q Corp in Oregon is a group of, it's a not-for-profit agency that is made up of insurers and providers and purchasers, and their whole job is try to create data sets that are accurate for every physician in the state, every practice in the state. And it's an uphill struggle, but I think Q Corp has done a reasonably good job.
I agree. And QCOPR is available online, drilled down to the patient-specific data level for all of us on our own patients. And for those of you that don't know about One Health Port, which I'm sure you know about, is plan by plan by plan by plan. You can drill down to your patients and get reports from them and problem solve it and correct them. When they put your 97-year-old patient on hospice on the list as somebody who hasn't had an LDL cholesterol checked.
So, I have to let you guys go.
Yeah, let's give Dr.
That-
Hacker a